from Dr. Stravinsky, and her bio is in the program, and I will not go into incredible depth on that unless you just want me to. But she is an amazing allergy immunology professor at UAMS and Arkansas Children's, and we are so excited that she is here with us today.
Thank you. Okay, so I'm going to share my screen, and give me just a second here.
Sounds good. Do I need to make you a co-host separately?
I don't know.
Nope,
I don't think so.
It says you're a co-host.
Yeah. I think she made us co-host. Katie made us co-host. Okay.
Yeah.
So the part that I practiced was the presenter mode with 2 screens after you and I met. So
gotcha, yeah.
And I did have to, do some Googling and YouTubing, but I think I've got it. So give me just a second here.
There we go.
All right. So are you guys seeing my title slide?
Perfect.
Yeah. Okay, good. So before I get started, I just wanted to point out, I'm going to be doing a little bit of polling during this session. So if you guys want to go ahead and try to get into that, you can either go to this website, pollevacherbin115, or you can text that to 37607. And then that way you guys can participate in the polls. I'll leave that up for just a second.
I'll go grab that and pop it in the chat too for anyone.
Oh, perfect. Yes, thank you. All right, well, thank you so much for the invitation to talk to you all. This is something that obviously we're very passionate about in the allergy division at Arkansas Children's Hospital. And so I wanted to give you guys just a bit of a refresher on sort of what the initial guidelines were, and then we can talk about some of the barriers and challenges that maybe we've come across since then, since they were initially recommended. Okay. So sadly, I have no conflict of interest to disclose because I don't do much beyond seeing patients. So, okay, so here are the objectives where I want to explain what the evidence is for the early peanut introduction, and then help you to identify who the right patients are for early peanut introduction, and then kind of talk to you about the best ways to implement these guidelines. So I'm going to kind of start general with, I know in clinic you guys come across frequently adverse food reactions. People often call them allergies. Everyone seems to have some kind of an allergy, but whenever in the allergy world, when we talk about it, we're very specific as to what a food allergy is, as opposed to a food intolerance, which there are many food intolerances or adverse effects of food. But when we talk about food allergy, we're very specifically talking about an IgE mediated immune response to an antigen that should otherwise be harmless, right? And so it can cause, potentially life-threatening symptoms. Whereas a food intolerance, though, it doesn't mean that it's not real. I mean, obviously, there are all sorts of things foods can do to our bodies that, don't feel good. And, there's some examples right there: lactose intolerance, food poisoning, MSG's on there, but, I don't know that that's a real thing. I can talk about that some other time. So, but basically there's something that when you eat the food, it doesn't agree with you and it doesn't make you feel good, but it is not life-threatening. And so this is a conversation we frequently have with patients in clinic, because everything I'm about to talk about really has to do with IgE mediated food allergy. We can't take these same principles and apply them to even non-IgE mediated food allergies. This is very specific, and sometimes it's hard for patients or for parents to really grab onto that. They kind of lump it all under the same group, and it is important for you guys as their pediatricians to kind of guide them through that. You know, one is potentially life-threatening, the other is not. One you can test for, maybe, the other one, maybe not. So are food allergies a big deal? You know, I feel like we definitely live in a time that a lot of people claim to have food allergies or food intolerances. It's very much a focus of a lot of like health coaching and things like that. And so when we're talking about, you know, IgE mediated food allergies, we suspect that there might be around 5% of the pediatric population that may have true IgE mediated food allergies, and that waxes and wanes. And now, honestly, I need to look at, you know, probably the most recent prevalence, because since we have instituted the early introduction, some of that has gone down. But the point here is that about a third of patients are going to tell you that, you know, there is some sort of adverse food reaction, but a large percentage of those are not life-threatening. So for patients that do have true IgE-mediated food allergies, the impact on the patients and on the families are huge. So there is, you know, obviously a physical component to it, making sure that a child can have adequate nutrition. If we're taking milk, eggs, soy, wheat, peanuts, tree nuts out of their diet, it doesn't leave them with a whole lot. So really making sure that, you know, their nutrition is optimized. And that is it's a big challenge for a lot of families. There's a social component to it. There are a lot of studies that have looked at children with food allergies who end up having often a lot more anxiety, sort of related to the fear of being exposed to one of their food allergens, because rightfully so, their parents and their doctors are teaching them that, you know, these are foods you should avoid, it might harm you. But the flip side of that is, you know, they might always be worried that they're going to eat something that's going to harm them. And there's also, in terms of school impact, sometimes for these kids, they actually do get bullied at school. I've had several patients in clinic that tell me, you know, they were chased around the playground with a food that they were allergic to. So those types of things can obviously be very traumatizing for them. And then sometimes the way schools address that is they say, well, we're going to take all the kids that have food allergies and we're going to put them separate from everybody else. That's also not great for their development either. It's really important that they be able to interact with other kids at lunchtime. It's a big part of their development. And then there's a big economic impact on families as well. And so this is something that our group has looked at in terms of food insecurity and food allergies, because you can imagine that if we're going to tell you that your child needs to be on a very restrictive diet, what you have available to you is going to be very limited. And then if on top of that, you add maybe any kind of socioeconomic stressors, that's going to be even more of a challenge. And so that's part of the reason why it's so important that we continue to do food allergy research. One, so that we can hopefully have better treatments, but even better if we can prevent them. So I was going to start with this clinical scenario and see what you guys think. So a 4-month-old male presents to clinic for a health supervision exam. He was a term newborn. He's currently exclusively breastfed. He's had normal growth and development. He does have some eczema, and he has an older brother with peanut allergy. So, and I'm going to make this a little bit easier for you guys with this next slide. This is his physical exam. So what do you guys think is the next best step? And I'm going to hold on just a second. Let me activate the poll. While I'm activating the poll, you guys can read the choices there. Okay, so it should be activated. You guys can try. Interesting.
I just have to say, this is really cool how you've embedded this.
Like I said, it took a lot of YouTubing and Googling, but I did it. I had done this for some of the resident lectures, like their board review lectures, and they all really liked it. So, all right. Excellent. So I'm going to move on to the next one. You guys did a really good job. Oh, it's still changing. Hold on. I think people are switching their answers at the last minute. I should have done this differently. I didn't think about that part. That's okay. All right, so it looks like the majority of the participants said that they would send a peanut IgE, which is absolutely true. So, and I'm going to sort of, get into this a little bit later. Obviously, it's a big chunk of the talk, but this is the right thing to do. So if you have a child that has what looks like severe eczema, you do want to send a peanut IgE, even though I know allergists have spent the last like 10 years telling people not to send IgEs, right? We're like, oh, please don't send the IgEs, let the allergist send them. But in this situation, that is the right thing to do. So why is it so important that we sort of identify these kids? So a lot of that comes down to this atopic march that I'm sure a lot of you guys are familiar with, but this is sort of the natural history of allergic diseases. In babies, what we're going to see first is their eczema. And so the severity of their eczema often correlates with developing some of these other conditions. And so the reason for that, we suspect, is that, when you have a defective barrier, you are now exposed to the environment, which includes allergens, includes obviously infection. And you would be surprised to hear there's actually a lot of like peanut dust and things like that that people are exposed to without knowing it. So sometimes people are like, well, I've never eaten that. How could I possibly become allergic to that? And that's, if you have eczema and you have an impaired skin barrier, then you can be exposed, you can become sensitized through a Th2 response. And so that kind of sets you up then for the rest of this, right? And so then, once they've become sensitized, they're more likely to switch from being sensitized to being clinically reactive to either food or environmental allergens. And then usually around the preschool years, the toddler years, they start to develop the wheezing and the asthma. As they get older, the eczema gets better, the food allergies start to resolve, they outgrow their asthma, though we all know nobody really outgrows asthma, but they become less clinically symptomatic, but then the allergic rhinitis sort of takes off, and that's the part that stays with people with atopic patients for the longest period of time. I do want to note, though, that doesn't mean any of the rest of this goes away, right? So you still have eczema, you still have asthma, and you still have food allergies, into adulthood, but it's definitely less prevalent. So I wanted to take sort of a step back into the timeline of our recommendations for food introduction, because, and we see this a lot with grandparents or great-grandparents of some of our infants, is they are still kind of stuck back here in 2000 when the AAP had recommended that high-risk children delay peanut introduction until the age of 3. And the thinking behind that was, you have these very atopic kids. So if we don't give them the food, then they won't become sensitized. And if they don't become sensitized, then they won't become allergic to it. And there was, some of this thought about like a leaky gut. And so maybe the gut is too immature to process those allergens, and then that's how they become allergic. But then by 2008, there was a really, really interesting study that came out where they looked at peanut allergy in comparable populations within the UK and then within Israel. And what they found is that children in the UK were 10 times more likely to have a peanut allergy than Israeli children. And so what they attributed that to was the fact that there is a snack in Israel that was very common called bamba. And it's basically kind of like, the puffs we give our kids, but it was peanut flavored. And so it had peanut dust all over it. It was a very common thing for babies to start eating early on because it was tasty and convenient. And so there wasn't any particular reason. It was more just what was available. But they thought, well, this must tell us that, maybe we're not doing the right thing by having, keeping the food out of the diet. So within a couple of years of that, the NIAID, which is the National Institutes of Allergy and Infectious Disease, they came out with some guidelines, and they said, okay, we don't have enough evidence to say that leaving it out of your diet is going to prevent the food allergy. So go ahead and, start putting into the diet. And there wasn't any, just as long as they're developmentally ready, don't specifically avoid it, but they didn't specifically tell you to put it into the diet. And then in 2015, we had this landmark study that was published in the New England Journal of Medicine that's called the LEAP study, and sort of revolutionized food allergy. And it was a very beautifully designed study that we'll go through, where they showed that through this early introduction, you can actually decrease the risk of those children developing a clinical peanut allergy. And so, and the reason that's really important is because peanut allergy is of all the food allergens, peanut allergy is the one that's most likely to persist into adulthood. So most milk and egg allergies will resolve. Certainly wheat allergy will resolve, but peanut it's tenacious and it sticks around for a long time. So if we can prevent that, then we might be able to make it a big impact on the natural history of this particular disease. So then in 2017, NIH made an addendum to the guidelines, sort of walking pediatricians through how to counsel your patients on introducing early peanut. So why is it really important that we sort of do this? Because it's much harder to look back and try to say, I don't know, is this person allergic or not? Because we don't have really good diagnostic tools. So we have peanut IgE testing, which is accessible. Most primary care providers can order it, but it's very easily misinterpreted. Not so much the negative results as positive results, because there are a lot of people that are sensitized, but not clinically reactive. And then there's skin prick testing, which is obviously less accessible, and you need an expert to be able to interpret the results of that. But also you can have false positive results as well with skin testing, because really all that indicates is whether or not somebody is sensitized. So neither of these tests tell us, is somebody clinically reactive? So, as we discussed, it has a big impact on these patients and their families if we tell them that they are allergic to a certain food. And so, hopefully we'll have better diagnostics in the future. There is, and I'm not sure, I'm guessing that probably, and you guys can let me know in the chat as well, I'm guessing that a lot of people don't send a ARH2, but basically this is a blood test that we use now to look more in terms of trying to predict a risk for a food challenge for a patient. So basically, when you have the peanut protein, there's several different epitopes. So, all these different pieces of that protein. And what we have found is that if you make IgE to the ARH2, that is actually the epitope that seems to correlate the most with patients that are going to have a clinical reaction. So in terms of who should, what I'll say is that up until recently, we really only used this if there was a pretest probability, a pretty high pretest probability that this person was allergic. So we didn't use it as a screening tool. Usually it was someone who had maybe had a minor reaction or we weren't sure, it was an unclear history. They're sensitized, but we don't know if they're clinically reactive. And then if their ARH2 is really high, then that might suggest to us that, hey, this person isn't only sensitized, but they're also clinically reactive. So that we still have a lot more to learn about sort of the durability of this sort of, or diagnostic durability of this tool. But and this is a study that came out last month, but there's been several studies where they've looked at this, and basically they did food challenges in kids, and they found that patients that had negative ARH2, even if they had a peanut allergy, passed their, or not peanut, even if they had peanut IgE, they passed their food challenges. And so those that have sort of moderately elevated, about half of them ended up having a true clinical allergy. And those that had significantly elevated ARH2, about 97% of those ended up feeling their food challenges. So the reason I bring this up is, this is usually something that we order in the allergy clinic. And however, sometimes, if that's something that's obtained by the PCP, then we don't need to repeat it. We can just kind of go on to the next step. There are several times when the PCP has appropriately sent a peanut IgE, but I still have to repeat it because I need to know those components in deciding whether or not that patient could safely have a challenge. Okay, so I want to go through the LEAP study because, like I said, this really sort of revolutionized food allergy for us. And this was a study in 2015. It was a prospective study. So what they did is they took infants that were at high risk of peanut allergy because either they had egg allergy or they had eczema. And so these are kids that were sensitized to peanut, but they were not clinically reactive. If they already had a clinically reactive picture, then they were not included in that study. So they took those sensitized high-risk patients and they put them into two groups. One group completely avoided peanut, which was the recommendations at the time. And the other one, they had them introduce it early and give it regularly in infancy. And so what they found is, of the children who ate peanut regularly and early, only 3.2% by the age of 5. So they started in infancy and they followed them for 5 years. Only 3% of those children had a peanut allergy. And then of the children who had been avoiding peanut, 17.2% of them had a peanut allergy. And remember, this was a group that was already at high risk of developing peanut allergies. So they were able to reduce the risk of peanut or the prevalence of peanut allergy in that population by 81%. So then they followed that with the LEAP ON study. And basically what they did is they wanted to know how durable was that response. So great, now we know that if you put it in their diet and they're eating it regularly, then they don't develop a peanut allergy. But if you take it away, then will they develop a peanut allergy? Because somebody that is truly peanut tolerant, they can, I mean, I'm not peanut allergic and I could go 5 years and not eat it and then be exposed to it and be fine because I'm not allergic to it. But for somebody that maybe has the tendency towards that or is at high risk, was it that we had sort of artificially decreased their risk by having them on that therapy? Or did we truly change sort of their tolerance to the food? And so in the LEAP ON study, they followed these kids and for 12, they told them, okay, take all the peanut out of your diet, both groups. And the ones that initially had the early peanut introduction, only 4.8% of those patients went on to develop a peanut allergy, whereas the patients that or the participants that had avoided peanut initially in infancy, after 12 months of avoidance, 18.6% of those were found to be allergic. So this suggested that, yes, this is a truly durable response. So it's not that we were just sort of suppressing it in infancy or as toddlers, but by putting this in their diet very early on, we get the immunologic mechanisms that we need for them to have a long-term tolerance to this allergen. So that is what led us to this addendum for early peanut introduction. So the first guideline in the addendum is that, again, we are looking at patients that have severe eczema or egg allergy. So if they have any of those things, then you should get a peanut IgE level. If the IgE level is negative, then in your clinic, or you can refer to us, the likelihood that they're going to have a reaction is pretty low. So you can actually tell them to introduce it at home if they feel comfortable, or you can do it in your clinic. If they have a positive peanut IgE, then we want to see them in our clinic so that we can go on to sort of stratify their risk of how likely is it that they're clinically reactive. And so this is the part that you guys focus on. This blue part is part of our decision making in clinic once we have the skin prick testing. And like I said, we also, it's not in the addendum, but we also look at the ARH2 as well to help us to try to predict the likelihood that that particular patient is going to have a clinical reaction. So, okay. So, as I said, you want to introduce peanut for the patients that are high risk. I mean, the ones that are at mild or moderate risk, certainly we should introduce peanut for them too, but obviously their risk of having a long-term peanut allergy is much higher. So these are the patients we really want to focus on and really want to encourage the parents to have this addressed and to hopefully introduce at home. So I wanted to sort of talk about the definition of severe eczema, because in the guideline addendums, what they classify as severe eczema is persistent or frequently recurring eczema that just has a typical morphology, right? Flexor surfaces or extensor surfaces on infants, and there's a frequent need for topical steroids and other types of eczema treatments. And this is obviously sort of generic because I think a lot of primary care providers are like, well, what's technically considered severe? And there's not a great consensus on what severe eczema is. There's very complicated sort of scoring that we can do on the research end of things, but it's not really very plausible in a clinic setting to do a SCORAD or an EASY score. So I think, and I don't have great answers for you other than using your clinical intuition. But I think this is an area where if we could offer more guidance for primary care providers to say, hey, this is a level of eczema where we get really concerned for peanut allergy, where they need to be introducing it. I feel like we could give better guidance, but this is right now what we have in the guidelines. So just wanted to bring that to your attention. And then the question of egg allergy comes up a lot too, because often, if we're doing this testing at 4 months, maybe they haven't been exposed to egg, and we don't know if they have an egg allergy. So in the guidelines, what they have sort of specified is either to have had a clinical reaction, or to have a positive skin prick test, or to have an oral food challenge. So certainly in the allergy clinic, if somebody is referred for severe eczema, then we will also test them for egg allergy. But I think that's also sort of difficult for primary care providers to navigate because sometimes the infant's too young to have been exposed to that yet. Okay, so you're going to, oh yes, so I just wanted to point this out. Again, I'm sure you have all heard this over and over again, but please, 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 please do not send a full panel of foods in these patients, because they will no doubt have a positive test for wheat or milk or soy or something they've never even eaten before. And as I mentioned earlier, being sensitized does not mean that you're clinically reactive. And it's very, very difficult to then go back and say, oh, okay, well, maybe you're not allergic to this. I know the blood testing looks like you are, but maybe you're not. And it, especially knowing that if we can get it into their diet, they have a decreased risk of developing that food allergy. We definitely want to err on the side of having them put those foods into their diet. So anything that deters them from doing that is harmful for the child in the long run. So, and we also sort of tell them to make sure that they introduce that other solid foods have been introduced and that they're developmentally ready. We obviously don't want them not being able to actually eat the food. Okay, and so then how much peanut do we need to put in their diet? And I think this is a good reminder for all of us, but the total amount of peanut protein that needs to be regularly consumed should be 6 to 7 grams for 3 or more feedings a week, okay? All right, so then breastfeeding, they did touch on this. And so whenever they looked at the nutritional analysis for the LEAP cohort, those infants that they followed from very early on, the introduction of peanut did not affect the duration or the frequency of breastfeeding, and it did not affect their growth or nutrition. And you can imagine, you know, if you're telling someone to now put this very high, you know, calorie, high fat, high protein food into their diet, that, you know, the thought would be like, well, maybe they're not going to be hungry anymore, and maybe they won't breastfeed, or maybe they're going to get too many calories, and you know, they'll end up, you know, being too high on their growth chart. But when they looked at that LEAP cohort, that was not the case. It didn't affect their growth. It didn't affect their frequency of breastfeeding. Okay, so if we don't catch them in that 4 to 6 month window, then let's say, you know, they have developmental delay, or, you know, it's a baby that was in the NICU for a long time, we still want them to try to introduce peanut into their diet. And so that's a question that comes up often as well. It's like, okay, well, let's say I have an 8-month-old or a 9-month-old, should I still try? And, you know, it is a good idea to assess them for it based on their risk. So if you have a 9-month-old that has severe eczema, you know, still follow that same rubric in the older patients, just knowing that by that point, they are more likely to have a positive test, but we should still look into it. And so if there are other household family members with confirmed peanut allergy, we really want you to talk to them about the risks and benefits of peanut allergy prevention versus the risk of a reaction in a family member. And this is something really difficult for families to navigate. You know, you have older brother has a peanut allergy, but we want to get it into the infant's diet. Well, what if older brother comes across it or has a reaction to it? And then, you know, how do we navigate that? But, you know, the treatment effect of the early introduction is really robust. So it is worth it to try to talk to that family about, you know, finding ways to maybe when older brother's at school, then that's when you give the baby the peanut, or when they're at somebody else's house or something like that, to sort of give them some tools, because a lot of families will understandably be nervous to then introduce peanut into their home when they've been peanut free for another sibling. Now, some families say that's too stressful and I can't handle it, and that's fine too. But it's not what's best for the infant. Okay, so for infants are at moderate risk, so they had mild to moderate eczema, they can just go ahead and put the peanut in their diet at home. There's no testing that needs to happen. If the family's like, well, I'm kind of nervous about it, you can definitely do a supervised feeding in clinic. The risk of a patient with mild to moderate eczema having a reaction to the peanut is very low. And then guideline 3 is for any infants that are at low risk. You know, they have no eczema or no food allergy. You can, again, tell them to introduce it in the same way with that 6 to 7 grams 3 to 4 times a week. And so here, I just in the HealthNet study, so this was a study that was done in Australia. And so 14% of their toddlers, or the 12 to 18-month-olds, had a confirmed peanut allergy, but did not have any risk factors. So yes, we're going to encourage them to, you know, put peanut into their diet, but that does not mean that all those kids are not going to have a reaction. It's still possible, you know, so somebody, you know, may be tolerating it for a while and they still may develop a peanut allergy, but the best thing to do is to get it into their diet as soon as, you know, they are developmentally ready for it. And I just want to make sure I'm doing okay on time. Okay. So here is a question for you guys. This is, so get your polling ready. And this is actually more for my information. I want to know, at what point do you guys typically talk to your families about early peanut introduction? Do you bring it up at the 2-month visit? Do you bring it up at the 4-month or the 6-month visit? So I'm going to activate that one. All right, so you guys should be able to, oh, hold on. There we go. Yeah, note to self next time, everyone second guesses their doubt based on whoever answers the fastest. Excellent. Okay. That's perfect because again, and that's part of the reason why part of the reason why we wanted to do this in the 4 to 6 month range, other than just sort of immunologically, they're sort of set up to develop their tolerance in that age range. But also it's hard to know at 2 months old if they're going to have an egg allergy, right? It's hard to know if they're going to develop severe eczema. So now by 6 months, we're probably pushing it a little bit because by the time the family feels comfortable, it may be too late. So the 4-month visit is sort of the sweet spot. Now, sometimes if you have a parent with who has a sibling with a peanut allergy, the 2-month visit is appropriate to bring it up because that's something they're going to have to sort of think through and decide their comfort level, knowing that you're going to bring it up again at their 4-month visit. Okay, so this is just a summary. So the first guideline is that if they have severe eczema, egg allergy, or both, then you should send a IgE level. If negative, they don't need a referral. You should have them introduce at home or in your office from 4 to 6 months of age. If they have mild to moderate eczema, then you can introduce around 6 months of age or earlier, honestly. And if they have no eczema or any food allergy, then just tell them to put it into their diet whenever they feel comfortable with it, because their risk is already pretty low. Okay, so when do we introduce it? One, they have to be developmentally ready for solid foods, and we discussed that earlier. And you really don't want that to be their first food exposure. You want to make sure they've had some cereal or some other baby foods, fruits and things like that, vegetables. And so then once you know sort of what they're, okay. So you want to make sure that the family knows that they're going to do this when they're at home. So that you don't want to do this at a restaurant. When there are plenty of parents to keep an eye on the child, well, at least 1 or 2, to be watching the child. And you want to make sure that they don't have like a runny nose or something like that. One, it'll decrease their threshold for having a reaction. But also, they may get some viral induced hives, and then we're confused. Well, was it the food or was it the infection? So. All right, and you want to make sure that you've talked to them about the signs of an allergic reaction, so they know what to do. All right, and so the way that we tell parents to do this is I'm going to go through the different types of foods that you can introduce, but basically you're going to wait for about 10 minutes and make sure that they don't have any symptoms, and then after that you can give them the rest of it over the next 15 to 30 minutes. Okay, so typically the foods that we recommend are, peanut butter that has been sort of thinned out with some breast milk or some formula that's warm breast milk or formula. And you can also add that to, baby food or cereal. This is also an option, which is this peanut butter powder. I've put some pictures here of some of the different products that are available at pretty much every grocery store that I've been to, because I always check just for funsies. And but they're all different brands. So just all they have to do is look for powdered peanut. And so for that, they would do 2 teaspoons, again, into milk or formula or cereal or whatever they want to mix it into. So that's the easiest way to do it. And then, of course, the initial studies were done with the Bamba. So this is more widely available as well now. So you can just take a few 21 sticks of it and mush it all up and make like a little cereal out of it. Okay, so one more question for you guys. What percentage of your patients introduce peanuts at home? Oh, sorry. There we go.
And we do have some really good questions in the chat, so I do want to try to save
Awesome. Okay, awesome. All right. Well, this is really encouraging to see that such a high percentage of patients are introducing the peanuts at home, and I'll talk to you about why that's important in just a minute. All right, so I just wanted to point out that there are some really good resources for parents and clinicians. And so if you go to the NIAID website, they actually have these really great handouts. I just did a couple of screenshots of how to, one, just explaining the early introduction, as well as how to introduce this. And then the Food Allergy Research Network also has some good stuff. I'm sure you guys get asked this in clinic a lot. There's a lot of other products now that are available where it's a mix of different allergenic foods and they introduce it at certain levels. I don't think I have time to sort of go into, I mean, I put in some slides here about that, but the quick story is that we have, yes, it can decrease your risk of food allergies, but it is very difficult to actually introduce that amount of food allergen into a infant's diet for it to be truly effective. So I don't necessarily discourage parents from doing it, but I also try to not have them, get their hopes up of that, oh, if I do this, then my child won't have food allergies, because it's a little bit more complicated than that. And also importantly, just like in the LEAP study, doing that where they introduced multiple foods into an infant's diet did not affect the breastfeeding. Okay, and so this is the last part I just kind of wanted to get to. So since we have implemented these guidelines, I'll say honestly, in our clinic, we had really prepared to have this onslaught of patients coming in that were going to need evaluation for early peanut introduction. And honestly, we haven't seen that many. And so that was one of the things that, we've been looking at in the past 5 to 6 years. And so there was a study that came out that found that there was actually a lot of barriers to guideline implementation. It seemed like a lot of it had to do with access to specialists and cost, and sometimes the parents just weren't interested. So I have one last question for you guys. And again, this is for my information, but what barriers do you find most problematic in implementing early peanut introduction? Is it that they can't get into allergy clinic on time? Is it that there's family resistance? Is it that they, you practice in a rural area, or they're too far to get to an allergist, or the parents just don't really care? Let's see here. Lack of interest from parents. Oh, and timely allergy consults. Okay, great, because that brings me to the next thing. This is my last slide. All right, we need your help. So this is something that we want to look into, because we want to try to learn what's the best way to facilitate implementing these guidelines. And so we're really trying to define the barriers to implementation. And we want to know, why is it that we didn't see as many? Maybe those patients just didn't need to be referred, or maybe they needed to be referred, but they never made it to our clinic, or it took too long. So we are going to be sending a survey out in October, and we would really, really, really appreciate you giving us some of that feedback, because if part of the problem is that they can't get into clinic fast enough, then we want to make that a streamlined process. If the problem is that, well, I can't convince the parents, then maybe we need to offer some more education or resources, or maybe some telemedicine doc-to-doc consults. So I just want to put that plug in. And with that, I will take any questions.
Thanks so much, Dr. Chervinsky. That picture of that kid covered in, all the kids covered in peanut butter. Yeah.
I love it.
We only have about 3 minutes until we are going to get very violently ripped back into the main session. So, okay. Dr. Burr asked, should we go ahead and test for egg IgE in those babies with severe eczema too, or just watch for clinical reaction with egg? That was a little earlier on, so I don't know if that question was.
Yeah, and that is a difficult question. What I would say is just watch for reaction, because a lot of them will be sensitized. Now, if their eczema is severe enough and you send a peanut IG and it's positive, then when you send them to us, we probably will test for egg at that point. But I wouldn't just screen by itself.
Dr. Averett asked, what are your thoughts about commercially available products to introduce allergens? And you touched on that a little bit.
Yeah, jury's out. Yes, we know that you can sort of sequentially introduce multiple food allergens to reduce the risk of developing food allergies, but the dosing and the timing and the frequency is still being worked out. So I can't say that those products don't work, but I also can't say that those products do work. So I can tell you it's not likely to harm them.
You shared a few of these too, but does anyone have good handouts discussing process or a website to send patients to?
Absolutely, yes. The NIH NIAID website has really, really great handouts for patients on sort of the practicality of how do you introduce it, and then the thinking behind why we're introducing it. So that's something you could hand out to your patients at the 4-month visit.
When looking at the peanut flavoring or peanut dust as in the Israeli snack, is the ARAH2
epitope
protein still present? Sorry.
Yes.
In other words, is it present in foods that are artificially flavored, or is there some other additive giving that flavor? That's a great question.
Okay, so that epitope is, so all peanut protein has that epitope. It's just that some people become sensitized to that epitope. So anywhere where there's peanut protein, they're going to have ARH2. It's just a matter of, we don't know which part the immune system is reacting to. So if it looks like they've made IgE to ARH2, then very likely then that they will have clinical reactions. So not everyone, but many of them.
All right, last question, if we can sneak it in. Do we still need to send to allergy if ARAH2 is negative?
If their peanut IgE is negative, I would say no, you don't need to refer them. They need to introduce, regardless of the severity of their other atopy. If you're going to send a peanut IgE and the ARH2 is elevated, that's just information for us to use should we decide to introduce or challenge or avoid or whatever, but not in terms of screening, no.
Dr. Chervinsky, we have a few seconds left. Thank you so much for all of your time and expertise today. It obviously was a very good discussion if you got so much chatter in the chat. Appreciate you so much. Any final thoughts from anybody before we all head back to the main session?
And I would just say, y'all feel free to email me if any questions come up or anything after this. I'm happy to answer those questions offline.
Well, thank you so much, everybody.